quite a broad area of anticoagulants and antiplatelets. It'll be far from complete, but I will try and cover some of the newer data, particularly with the DOACs or NOACs. This is where I work at St Thomas's. Our office is around the front here of this building here. We look across at the politicians, which is nice, but what's not nice is that they look back at us. We've had a building there for a long time. That was the original St Thomas's, but Thomas Guy, that was a sort of almshouse from the sort of 11th century. But Thomas Guy gave a lot of money to St Thomas's, so it moved over here, and then they built Guy's on that site. These are my disclosures for research support and honoraria. And for the purposes of this meeting, I'll point out that I receive funding and honoraria from many of the companies that make anticoagulants and antiplatelet agents. My talk today is really in three sections. It's about anticoagulants first, and I'm going to cover a little bit on atrial fibrillation and VTE, or venous thromboembolism. I'm not going to talk about other settings like adult congenital heart disease and LV thromboses, which I also see in my clinic. I'm going to have a minute or two on antidotes for the DOACs. Then I'm going to move into antiplatelets and really just very briefly cover some work in the coronary circulation, not the peripheral or the neurovascular circulation, talking about the coronary syndromes, and then finally I'm going to talk about the combination of anticoagulants and antiplatelets. So let's start with AF, and because the Mayo Clinic are part of this, I think the Americans will tell you that it was C. Miller-Fisher, as in the Miller-Fisher syndrome, that first suggested that AF caused stroke and embolism. The Americans always claimed things first, but actually it wasn't. It was William Gowers from UCL. He didn't associate AF so much, but he definitely looked at embolism causing stroke, so emboli from the heart. He didn't associate it with AF, but William Gowers, I think he's still working as a consultant at Queen Square, actually. It's amazing how difficult it is to get a job in this country. So I've been here 32 years and I still sound like an Aussie. So what about the non-VKA or the oral anticoagulants? Well, they're just generally better than vitamin K antagonists. I mean, these are the various studies. If you look overall, they're probably a bit more effective at preventing stroke. Overall, there's about a 20% reduction in preventing stroke. They're definitely better at not causing intracerebral hemorrhage. They may not make that much difference to ischemic stroke, but some of the higher doses of dabigatran do, and they definitely affect all-cause mortality. And from a safety point of view, the major bleeding varies, but generally speaking, major bleeding is not increased. If anything, it's decreased with DOACs. So that's why most of the guidelines recommend NOACs or DOACs. I'm going to ask you a question now. When you've got a patient in front of you and you're saying to them, I think your CHADS VASC is 2 or 3 and I'm going to start an anticoagulant, do you say I'm doing that to reduce mortality, to reduce ischemic stroke, to reduce stroke and systemic embolism, reduce MI, myocardial infarction, peripheral vascular disease, or for the early diagnosis of cancers because you flush them out with an anticoagulant? What do you say to your patients? What's the most important benefit of starting anticoagulation? So please vote. Sorry. Polls open. Are you able to vote? Oh, well, you have voted. You're quick. Reducing mortality 5%, reducing stroke about 1/3, combination about 60%, MI and PVD rates, none, early diagnosis. All the answers are correct. All the answers are correct. I actually say to patients, the reason why I'm starting you on an anticoagulant, I don't talk about stroke. I say because you'll live longer. You're not going to die as quickly, despite the bleeding, as someone who isn't anticoagulated. What's my evidence for that? Well, evidence is a funny thing, you know. You can look at things like stroke, bleeding, whatever, and you can say that's a duck, and then you say, no. Look at it the other way around, that's a rabbit. There's only one thing that George Bush Jr. got right, and that was dead or alive, because that is a binary outcome. There's no bias in dead or alive, and you all, as cardiologists, should know Bob Hart and Bob Hart's meta-analysis from 2007. And you should know Table 5 of Bob Hart's meta-analysis from 2007 if you ever treat a patient with atrial fibrillation and you anticoagulate them, because even with warfarin and coumadins and other vitamin K antagonists, down the bottom here, the George Bush dead or alive all-cause mortality was reduced by 26%. Significant 20% reduction in all-cause mortality. That's the best net clinical benefit you can ever get. And DOACs do 10% better than vitamin K antagonists. So that 26% becomes what, 29, 30%? When you start an anticoagulant in a patient with atrial fibrillation, you should be telling them, I'm doing this so you'll live longer. That's the first thing. And by the way, it also reduces stroke, systemic embolism. It has an effect on myocardial infarction if you choose a factor 10 inhibitor or if you choose a vitamin K antagonist. It also affects probably peripheral vascular disease. So what did we do when we developed the DOACs? We looked for things, and we looked for lots of things. We thought, is it as good at preventing stroke as vitamin K antagonists? And yes, they all are. Is it a lower risk of intracranial bleeding? Yes, they all are. Does it reduce any stroke? Well, apixaban and dabigatran do. Is there a lower risk of ischemic stroke? Only with dabigatran 150. Is there a lower risk of extracranial bleedings, major bleeding? Yes, they all seem to be, but mainly apixaban, dabigatran and edoxaban. Is there lower vascular mortality? There was. They're all orally bioavailable. They have fewer food and drug interactions, but they've still got important drug interactions, which we mustn't forget. They've got a broader therapeutic window. You can just halve the dose. Certainly in VTE, you can just halve the dose, and it's still very effective, our studies have shown. They've got predictable anticoagulation without monitoring, and you don't need to monitor patients very often, even your large patients. That's a complete waste of time. We've just presented evidence on that last year, and it's more acceptable, and they stay on it for longer. So let's move to VTE. Let's leave atrial fibrillation, and this is one of my patients. I actually did this venogram at King's College Hospital in 1988 or 89, and this is a proximal DVT of the femoral vein. It used to be called the superficial femoral vein. And this is a typical PE, sometimes with a bit of right ventricular enlargement. These patients would have got in the DOAC studies. This patient probably wouldn't have because this patient was shocked and probably required thrombolysis. So when we treat VTE with DOACs as opposed to low molecular weight heparin and warfarin, what are the main benefits in treating VTE patients with NOACs rather than VKA? Is it reducing mortality rates? Is it reducing recurrence rates? Is it the long-term use in thrombophilia patients, reducing bleeding rates, or improved adherence and long-term use? So please vote now. And I thought there might be some numbers I can see, but I can't. But you'll tell me when they're voted, when you've got a vote. Shall we? Yeah, okay, I'll press again, see what happens. Great. So, Giving anticoagulation to PE patients reduces mortality. There's no evidence that DOACs are better than vitamin K antagonists in reducing mortality in VTE, unlike atrial fibrillation. They don't seem to make that much difference to recurrence rates, except in elderly, frail patients where they're better. They're not that favoured for certain thrombophilia patients, particularly patients with antiphospholipid syndrome that's triple positive. You wouldn't use it, you'd use VKA, but it is useful for long-term use. The key is that it reduces bleeding rates and there's improved adherence again. So most of you got that right. What does a clinician want to know when you're choosing a NOAC or a DOAC versus vitamin K? What's the overall efficacy? What's the risk of major bleeding? And are there differences between the factor 2 inhibitor, dabigatran, and the factor 10A inhibitors for efficacy and safety? So this meta-analysis, which was, I'm sorry, Nick Van Es did this one in Blood in 2015 or 14. You can see here that as far as efficacy is concerned, there's no difference between the factor 2 inhibitor and the factor 10 inhibitors. They're the same, and they both overlap one, so there's no difference from warfarin. Efficacy is the same. For major bleeding, no differences between dabigatran and factor 10 inhibitors. It's just that you get about a clear 40% reduction in major bleeding with the factor 10 inhibitors. So you shouldn't use VKA if you can avoid it. What sort of bleeding, though? Is it true for DVT and PE patients? Is it the same? Is it true for obese patients? And we've done trough levels on 120 obese patients between my colleagues at Addenbrooke's in Cambridge and our group at Guy's and St Thomas's. We haven't found a trough level that isn't in the therapeutic range. And the average weight of these patients, 160 kilograms, varying from 120 to 240 kilograms. So all this rubbish about not using DOACs in overweight people or big people is rubbish. So what about the differences between PE and DVT? No differences, just as effective for efficacy. No differences with body weight. But these studies had very few heavy patients, and that's why we've done these observational studies. What about what sort of major bleeding? Is it important, the major bleeding? What about gastrointestinal bleeding? What about non-major bleeding? Well, here we go. What is using a DOAC? Why is it using a DOAC better than vitamin K antagonists? Because you reduce your chance of bleeding and dying from bleeding by 2/3. That's pretty good. You also reduce your chance of bleeding into the brain by 2/3. Why would you use a vitamin K antagonist? No difference in GI bleeding in VTE because they're different from AF patients. They're not as many on antiplatelets. And this is important, about a quarter reduction in clinically relevant non-major bleeding, because clinically relevant non-major bleeding is not innocuous. There are 5 clinically relevant non-major bleeds for every 1 major bleed, and we've just costed them recently. A major bleed costs about £5,000 per bleed. And we did this in a rigorous way. We did a propensity scored analysis, we matched them, and we used a subtraction technique. About £5,000 or £6,000. A clinically relevant non-major bleed is coming into hospital with GI bleeding, urological bleeding, respiratory bleeding, but not having a 2-gram drop in haemoglobin and not having a transfusion. They still cost £3,000. So if there's 5 of those for every 1 major bleed, actually clinically relevant non-major bleeding costs us a lot more than major bleeding. So when you see these cost-effective analyses and they cost clinically relevant non-major bleeding at £60 or £100, they just haven't costed it. It's not true. It's expensive. And look at the difference between bleeding. This is a sub-study that we did of the Amplify study, looking at apixaban versus low molecular weight heparin warfarin in PE patients. That's efficacy, no difference. Look at major bleeding. That's standard of care, that's apixaban. 80% reduction in major bleeding. Why do we see the bigger reductions in bleeding in PE? Because we treat PE patients far more aggressively than we treat DVT patients. Have we got evidence for treating PE with anticoagulants? Yes, we have, from Barrett and Jordan in 1960. Have we got any evidence for treating proximal DVT with anticoagulants? Not a single scrap. Not a single scrap of evidence to treat proximal DVT. There's never been a randomised trial of proximal DVT versus placebo because the PE data was so overwhelming. There's been some distal studies done with treatment or no treatment, but nothing. So we extrapolate. We practiced imprecise medicine, and I welcome imprecise. We should practice imprecise medicine because clinical trials are too restrictive. Why am I banging on about bleeding? Because if you look at this work from that was the Rieti registry, that in the first 3 months, the case fatality rates for VTE and bleeding are the same. But after 3 months, the case fatality rate for bleeding stays the same, whereas the recurrences are less likely to be fatal. So bleeding's important because it has an effect on mortality. And if you can reduce bleeding, that's a good thing. Righto, antidotes. What's the evidence for using antidotes for anticoagulants? Is it strong? Is it non-existent? Is it based on RCTs for NOACs? Is it based on a clear RCT for vitamin K antagonists? Or is it based on single-arm studies for NOACs? Please vote. The evidence for antidotes for anticoagulants. What do we got? Yeah, it's pretty good. That's good. Yeah, it's almost non-existent. There's no randomised control trials for NOACs. There is a randomised control trial for VKA. It didn't work. That was Rudy Serode's paper in bleeding with vitamin K antagonists. They gave PCCs. It made no difference to mortality, made no difference to outcomes. The bleeding didn't stop more quickly. The only thing that happened was the INR returned to normal. They still bled with PCCs. They might have had slightly less transfusions, but it was no significant difference. We give PCCs, we don't know what it does. We don't think it does as much as we'd like to think it does. There's no evidence for any randomised controlled trials, but there is a randomised controlled trial going on with an antidote for NOAC, the Anexa-I study, and it's mainly based on single-arm studies for NOACs and vitamin K. So here's the level 1A evidence for reversal agents for direct oral anticoagulants. There is none. But there are 2 studies we've done, and the iduricizumab study for dabigatran, and an interesting study, really good results with respect to mortality and stopping bleeding in a single-arm study, but their outcome was not adjudicated. And then the more rigorous study, which I happen to be involved in, the Andexanet alpha study, which was the Anexa-4 study, which we also published in the New England Journal, and that also showed really good outcomes. I mean, if you look at the clinical trials, patients with intracerebral hemorrhages on NOACs, the mortality rate was between 35 and 42%. In this study, the mortality rate was 15%. Of course, they're not the same patients, and you can't easily compare across studies. But these studies give a strong indication that these antidotes may have a role. We don't know, but they're approved, and I think we should consider using them. And they're being... iduricizumab didn't even go to NICE. It's never been NICE approved. It's just on the market. And Andexanet alpha is going to NICE. And I'd be happy to talk more about antidotes, but for the sake of time, I'll keep going. Antiplatelets. And I'm going to talk very briefly about acute coronary syndromes and then chronic coronary syndromes. So thanks to Rob Story for some of these slides. At to start off, I've really been talking about these drugs up here, the vitamin K antagonist, which act on thrombin, but also thrombin not only has an effect on coagulation, has an effect on platelets. But now we're moving over here to the P2Y12 inhibitors. And we did a lot of work in the past on the 2B3A inhibitors, but where that is still around, but less, and not something I'm going to cover today. So we know from the DAP study that if we use dual antiplatelet agents after patients have had an MI, we know that it's effective in reducing most of our cardiac outcomes: MACE, cardiovascular death, MI, stroke, and even stent thrombosis. But we know there's also a price to pay with dual antiplatelet therapy. We've got increased major bleeding events, no difference in overall mortality. And the major bleeding is sometimes associated with mortality, as we saw in the OASIS studies many years ago. So what about some of the more recent data? Well, if I start with PCI, because I'm not going to cover the ACS data show that these drugs are effective, but if we look at PCI, I think there are a couple of interesting studies. I think the ISR SAFE study is interesting because I think that helped us decide how long do we use antiplatelet therapy and dual antiplatelet therapy after PCI in patients who are having drug-eluting stents. And clearly, 6 months of clopidogrel was just as good as 12 months, but was associated with fewer bleeding events. More recently, people have been looking at ticagrelor and prasugrel, and I think there's an interesting study which I should draw your attention to, the Twilight study, which with ticagrelor, PCI patients again with dual drug-eluting stents. And here the dual antiplatelet therapy was aspirin and ticagrelor, and there was no difference in the efficacy, so I'm just showing you the safety. And it seems that monotherapy with ticagrelor in this setting is probably better from a safety point of view than combining ticagrelor with another antiplatelet in patients having PCI. I'm not going to talk about all the ACS studies with prasugrel and ticagrelor, but I'd be happy to discuss those later. More recently, the European Society of Cardiology have been very interested in what they call chronic coronary syndromes. People used to refer to this as stable coronary artery disease. Nobody thinks it's stable anymore. When you look at the follow-up of patients, they're not that stable. In fact, they continue to have events. So my question to you, and my last question is, in chronic coronary syndromes, long-term dual antithrombotic therapy may be indicated for higher risk patients. 2, bleeding risk helps determine the type and duration of antithrombotic therapy. 3, AF patients now with stable vascular disease may be treated with just anticoagulants. 4, all of the above are true. 5, none of the above are true. Please vote now. I hope this is the easiest question of the lot. It clearly is the easiest question of the lot, because I think all of the above are true, that we take most of these factors into account, and 80% of you also think that. I'm glad someone said none of the above are true. That's always good to have a non-believer in the audience. Very nice too. So what do we mean by dual antiplatelet or dual antithrombotic therapy? And really it's a bit of a mixed bag based on the studies. And really what we've got for options in patients who require dual antithrombotic therapy are clopidogrel with aspirin, prasugrel, rivaroxaban, and ticagrelor. And I think that they all have slightly different indications, and they all have some additional precautions. With just about all of them, you have to be concerned about the risk of bleeding. and you need to take that into account. So that's not on that slide, but we'll come back to that. But as far as clopidogrel concerned, it's fine for post-MI patients, particularly if they've already tolerated a year of dual antiplatelet therapy. For prasugrel, post-PCI for MI patients. Same for rivaroxaban, but in rivaroxaban, they also not just looked at post-MI patients, but they looked at patients with multi-vessel coronary artery disease. And for ticagrelor, post-MI patients again. There's some warning about age in patients with prasugrel, and of course renal function in patients on rivaroxaban. The key here, I think, is to recognise the high-risk patients, and I think that this particular study from Banaka in Lancet Diabetes a couple of years ago is interesting, because if we look at the rates of cardiovascular death, MI and stroke, you can see that in non-polyvascular disease, non-diabetic, so people with coronary artery disease basically, the rates are relatively low. You add in diabetes, it becomes higher. You add in polyvascular disease and no diabetes, it becomes higher. You add in both and it becomes really high. So the risk factor profile should help you determine who you consider for dual antithrombotic therapy. So I'm just going to summarise the data because I think there's so much of it. Long-term dual antiplatelet therapy reduces ischemic events following MI and in patients at high risk of cardiovascular disease, but there's a cost of more bleeding. Excluding patients with risk factors for bleeding, such as anemia or prior bleeding, is an important thing to help the benefit. And although the relative risk reductions are fairly similar across the group, the absolute benefit is greater in those at high risk, as indicated here. Things like multivessel disease, diabetes, chronic renal impairment and coexistent PAD. The further guidance on this comes from the ESC guidelines, and I think that what we really need to think about is in patients who are in sinus rhythm, adding a second antithrombotic drug to aspirin is important if they're at high risk without a bleeding risk, high bleeding risk. But adding a second to patients who had moderately increased risk, and they've defined this here, is not such a strong recommendation. So you really have to choose your patients and think about how high a risk they are and what their risk of bleeding is. Finally, I'm just going to cover in the last 4 minutes, anticoagulants with antiplatelet drugs, something that we in the haematology department are always concerned about, and something that you really need to have cooperation and balance, and that's between the haematologist, the cardiologist, the vascular physician. In fact, cooperation and balance, as you know, are the keys to success. And in this situation, it brings me to the COMPASS study. And the COMPASS study, I think, is a very interesting study that you're probably aware of, that looked at rivaroxaban and aspirin, or rivaroxaban at a higher dose on its own, or aspirin on its own. And what we saw was that overall the efficacy was clearly in favour of rivaroxaban at 2.5 BID plus aspirin, more than rivaroxaban on its own and more than aspirin on its own. And that's the overall findings, but there were some groups that did particularly well. And those groups that did particularly well were the high-risk patients, and also the patients with peripheral arterial disease. The thing that you have to deal with in this situation is the bleeding. And choosing patients at low risk of bleeding is very important also. So I don't think this is going to be a universal uptake, but I think it's going to be something that we think more of in our patients with vascular disease. I'll come back to one point I made earlier, that in the COMPASS study, if you looked at total mortality was reduced in patients in the combination of rivaroxaban plus aspirin. So if you want net benefit there's no net benefit better than total mortality. So overall, you're going to live longer, maybe with a bit more bleeding, if you have the combination. The other time where we think about combining antiplatelets with anticoagulants is in PCI. And I'm just going to show you the Augusta study because that's the more recent study. There are lots of other studies with, there's the rivaroxaban, the Pioneer AF study, there's the dabigatran study as well. And in this study, published last year, the primary outcome was major or clinically relevant non-major bleeding. And if we look at that, aspirin and vitamin K antagonists, it was high. It was lower significantly with apixaban and aspirin. It was also high with vitamin K and placebo, and lower with apixaban and placebo. I mean, and not major differences in the thrombosis rates, except some early stent thrombosis, which I'll come back to. I mean, this message comes through whether we look at VTE, AF, PCI. Some things are safer bets than others. And I've always loved playing the old rock, paper, scissors with my kids, and scissors always beat paper. And I think in these times of, how will I put it, popularism, this is an important slide. Let's go on to antithrombotic therapy post-PCI in patients with AF and other indications. Generally speaking, because we're worried about stent thrombosis, in patients undergoing this, peri-procedural aspirin and clopidogrel are recommended. And in many patients, they can get the normal doses of the DOACs. But in lots of other cases, particularly with rivaroxaban and dabigatran, it's recommended that you step down. You step down the rivaroxaban to 15 twice daily, and particularly patients at high risk of bleeding and lower risk of thrombosis, and you step down the dabigatran to 110 twice daily. If it's an uncomplicated PCI, then you should probably be able to stop the aspirin and continue dual therapy with an oral anticoagulant and clopidogrel. But for higher risk patients, you consider triple therapy for at least a month, and if not longer. And it depends whether it's a PCI or post-MI. So if it's post-PCI, it's shorter. Post-acute coronary syndromes, it's longer. So in summary, and I'm just a bit over time, I'm sorry, AF patients, dual long-term option is oral anticoagulant monotherapy after 12 months. If the patients are stable, you can just treat them with oral anticoagulants. But dual therapy with oral anticoagulants and aspirin or clopidogrel may be considered for higher cardiovascular risk patients with bleeding. And at that point, I'll say nothing more, except that that nice-looking bird there is the male, and this one's the female, and I'm married to a doctor, and it's nothing like that in our house. Thank you very much.